Okay, Professor Moraes, are you ready? You have to unmute your microphone.
Yes.
Yeah, great.
Already. Yeah.
Okay, so it's time, so let's begin. And yeah, thank you very much to everybody for joining us today, as every month, to this month's LACES Crown Round. Today, we are going to have the talk from Professor Moraes from Brazil about mitral valve repair in patients with infective endocarditis. And we have also the pleasure to have the moderation from Dr. Enrique Seguel and Dr. Aleck Stockins from Chile. They are going to be the surgical moderators of this talk. And we also have, for the very first time, the joint participation of representatives from the Sociedad Sudamericana de Cardiologia, the South American Society for Cardiology. And we have the participation from Dr. Daniel Barrocal. He's an interventional cardiologist from Argentina. And Dr. Andrea Simeone, she's a clinical cardiologist from Uruguay. And the idea is to have a hard team discussion with a perspective from both sides, the surgical and the cardiology side. So we are very happy to count on your participation. Because of the international participation, the talk is going to be in English, but please feel free to use whatever language you actually prefer. And we are, of course, happy to help with the translation if it is required. And just please raise your hand if you have any question or comment, and then the moderators will give you the word, or you can also write the question or comment in the chat, and we are happy to read it for you. So, Dr. Seguel, I give you the word, and just please go ahead. It's your time.
Well, thanks, Mateo, for this opportunity, and thanks for the Latin American Association for Cardiosurgery and Endovascular Surgery. I'm very glad to be here to talk about this very interesting theme. So we have extremes, people who believe that every infected valve should be replaced, and people who can repair even an infected valve. So glad to meet you, and I hope to have a very interesting discussion. So I left you, Dr. Moraes, please, to join your presentation.
Thank you all. Thank you, Mateo. Thank you, Dr. Seguel. First, I'd like to say that it's a privilege being here, having the opportunity to discuss with all of you a very, I would consider a challenging case. I will try to briefly present the case and then show some images taken during the operations, where we could stop a little bit and elaborate and discuss a little bit what I think is the main object of this meeting, is take the opportunity to discuss mainly when we discuss very challenging cases. I have separated the two cases, but perhaps we have time just to go over one of them. This is a 61-year-old male with a past of at least metabolism that presented prolonged fever, and he also presented a cerebral embolism. Then the echo, the transthoracic echo, showed a severe mitral regurgitation, and during this echo, it was possible to identify a chord rupture in the left, the posterior leaflet, and also some very strange image in the anterior leaflet that we can show during the echocardiogram. Then this patient was hemodynamically stable, and the physicians had already started antibiotics vancomycin. As you can see, this is the chest X-ray. Nothing very important was shown in this chest X-ray. As you can see, the diameter of the heart is almost normal. Nothing else important to point out. Then, if you want to interrupt and ask any question, please feel free. Then this is the echocardiogram that we'd like to show you and to discuss a little bit. As you can see, let me repeat here and stop. As you can see here in the posterior leaflet, we can see a rupture of one of the chordae at the P2 level. And also, you can see here in the anterior leaflet, very close to anterior annulus, also at the region between A2 and the mitral valve ring. As you can see, there is a hole in this area. When we go to the Doppler, to the color, as you can see, there is a huge mitral valve regurgitation, a huge mitral regurgitation. I could at this moment ask the audience if someone would like to make any comments about these images, these echo images.
Dr. Moraes?
Yes.
At this time, did you identify the bacteria, the germ?
In this case, it was Staphylococcus aureus. I'm sorry, not being reported here.
And the patient had a cerebral emboli. What was the neurological impairment of this?
It was a very transient, no permanent neurological damage in these patients.
And at this time, I ask you and the audience, when a patient had an cerebral emboli, how many times did you wait before surgery?
Well, that's a very good point. In the past, we have used waited a long time, at least 1 month, to indicate operation. Nowadays, once the patients do not have no signs of hemorrhage, here in our place, in our service, we try to go straight forward to the operation. In a scenario like this, I'd like to stress with you, because in this case there is a huge mitral valve regurgitation. You see, although the patient was stable hemodynamically, but with this rupture at the P2 level, and also with this hole in the anterior leaflet, we decided to go ahead with the operation once the patient was awake and with no permanent neurological deaths and no signs of bleeding, cerebral bleeding.
I wanted to ask something or just add a question, comment, if I may.
Yes.
It's actually very interesting because the likelihood of being able to repair a valve in endocarditis is very dependent of the time or the timing of the operation, because if you wait too long, then probably you are not going to be able to repair it because the valve is going to be destroyed. So this case is actually very difficult to take the decision, because on one side you have a massive regurgitation, you have a Staphylococcus aureus, which is a relative indication to do the surgery soon. But on the other side, you have the cerebral event, and you will actually like to wait. So it's actually very difficult.
Yes, Mateo, I agree with you. That's why I brought this case to discuss here. I think it's a very challenging case because there is a massive mitral valve regurgitation with an early brain insult. But once the patient was awake, hemodynamically, stable, no signs of cerebral hemorrhage, we decide to not wait more. And once we have quite a big experience in repairing mitral valves here, we decided to go ahead and try to see what we could do in this case. Well, I think we should go ahead and see what we observed during the operation. Then the patient was operated through median sternotomy. Cardiopulmonary bypass was started, and this was a brief video of the operation. This is the first part, showing the aspect of the valves. We usually put these sutures on the ring because it facilitates quite a lot the exposure of the mitral valve apparatus. As you can see here, the anterior leaflets, you will observe an important, a very big hole in the anterior leaflets at the level of A2, as you can see here. As you can see here, a very, very big hole. We had shown it during the echocardiogram, as you can see here. And also, in the posterior leaflet, as you can see at the level of P2, cord rupture at this level, as you can see here. As you can see, the P2, and this is the rupture cord here. Then we thought if we could repair this valve. That's a good question. And how to do this repair? If we could do a triangular resection and suture the reminiscent of this segment of the posterior leaflet, and then repair also the anterior leaflet. Then that's what we did here. As you can see, first we started repairing the posterior leaflet of the mitral valve. As you can see here, we put a stitch at the extreme of the P2 segment in both sides, and then we did a triangular resection at this level, as you can see here. Showing once more. I usually put 2 stitches with 5/0 stitch at the extremes of the P2, and then apply the triangular resection, where it could resect all that infected tissue.
Dr. Moraes, there's
Yes.
someone who want to ask some question. It's Juan, please.
Yes. Please, Juan.
No, he's with his hand over.
Fernando, this is not Juan, this is Aleck, Stockins. So just a quick question. You did a triangular resection, but just limited to the destroyed part of the valve, right? You didn't go up to the mitral ring.
Yes, yes.
Okay.
Not
so
at the ring, at the level of the ring.
Okay.
Just that area where there was a infected tissue. As you can see, at the level of the P2, close to the mitral ring, the tissue was quite
healthy.
Quite healthy, quite normal here. And then we thought we could apply the triangular resection with quite a safe zone. We have tissue. Can I go on?
Yeah, go ahead.
Yeah.
Professor Moraes, may I ask you a question?
Yes, Mateo.
I don't know if you do neocords, but if you do, why did you decide for the triangular resection? Like, why did you prefer the resection instead of the neocords? Is there any reason, or?
Yeah, usually in my practice here, I usually in situations like this where there is a rupture of the cord at the P2 level, I usually apply the triangular resection, but sometimes I use the PTFE cord, mainly when there is a prolapse of the anterior leaflet. To repair the prolapse of the posterior leaflet, I usually apply a small resection in cases like this, and implant a ring.
Dr. Moraes, it looks like in the anterior leaflet, at the level of the perforation, there is active endocarditis. How you deal with this? It looks inflammation, red, I don't know.
You mean in the anterior leaflet?
Anterior leaflet, yes.
Yeah. You see, I will resect all this tissue around, very soft and fragile tissue, and I will let just the health tissue, and then I will repair this segment as well. I will show in the next video, okay. I think.
Fernando, last thing, Mateo, I think you have to unmute some people for them to ask questions. And Daniel Navia is asking is in queue to ask a question, but I am afraid you have all of them muted. So I don't know if
you know, exactly. If you want to talk, you actually can unmute yourself. Daniel can just unmute his microphone and then he can speak.
You hear me?
Yeah, we can hear you.
Hi guys, how are you? Nice video. The question that I have, sometimes I don't know which was the pathology of the mitral valve before the infection, because sometimes I prefer to resect just only the infection tissue without going away from the non-infected tissue, because sometimes the valve is not so, there's no so disease before infection, and if you make a big resection, sometimes the posterior leaflet is not good enough after to suture, and they had some problem because of you resect a lot of tissue in the posterior leaflet. And the anterior leaflet is I think you already put a patch there as a good alternative. But in the posterior leaflet, when you don't have enough tissue, sometimes it's easy to resect only the infected tissue. And maybe like Mateo said, put a cord there and not to resect very important part of the normal tissue.
Yeah, I agree. But I think in this case, I think it was very useful to resect that area where I showed in the video here, and then I suture the both extremes of the P2, as you will see. I think you can use both techniques in a case like this, but I think I was more comfortable resecting this area. Perhaps this patient, he could have this, at this level, he could have an elongated cord at this level, and then with the infection, at the end, it ruptured. But that's what I decide to do in this case.
Mhm.
Let's see what the next video shows. As you can see here, the extremes of the P2 level, the suture was applied in here in P2, repairing this segment at this level. Then I moved to the anterior leaflet, where I resected this fragile tissue around the infected area, and then I applied a pericardial patch, as you can see in this video now. As you can see, it is very easy in this case. I suture a pericardial, bovine pericardial patch, as you can see here, repairing that hole in the anterior leaflet, as you can see here, and in the suture. And at the end, we implanted a ring. I don't remember the number, the size of the ring in here, and then was inspected how the mobilization of the leaflets. I was a little bit worried here because there was an indentation between P1 and P2 here. Then I needed to apply another stitch to close the indentation between P1 and P2. As you can see here, I need to put another stitch here.
Well, Dr. Moraes, Juan again is asking for a question. Please, Juan, open your microphone.
Hi, thank you to everyone. Really good repair, Dr. Morales. Do you have any experience with another material like core matrix, autologous pericardium, or you just use bovine pericardium?
No, I usually use the bovine pericardium, but I had the opportunity to use in one child 2 years ago, a decellularized bovine pericardium. We don't have here in Brazil the core matrix tissue that is decellularized as well, as far as I know, but we don't have it in Brazil. We have one made in Curitiba by Cardioprotes, but we didn't use it in this case. We could use also the autologous pericardium, but in our practice, we regularly use the bovine pericardium to repair most of these intracardiac defects and
Mhm.
Then this is the final aspect of the valve, as you can
Yes.
see.
Dr. Navia?
Yes.
Very nice case, Fernando, very nice videos. The concern that I try to mention is what happened to P2 and P1 indentation that you have. It happened to me in the past, because when you're doing a high resection, or actually quadrangular resection is more frequent, but also in the triangular resection, when the posterior leaflet is small, you got some cortine effect that the P2 become very small and traction and make a sort of a new indentation in between P1 and P2. But I think this is a new indentation secondary to the triangular resection, actually quadrangular resection. It happened to me a couple times in the past. Now we are very conservative and we try to respect instead of resect a lot. And that's what I mentioned before, that we recommend to just only resect the infected tissue and preserve the most important part of the tissue, the posterior leaflet, to avoid this. Because sometimes you put the stitches and a stitch between P1 and P2 indentation, and the tissues start to tear, and they had a big problem sometimes. That's why it came to be more conservative in the last couple of years, because it happened to me a couple of times.
Yeah, that's a good point. I take your point, and perhaps that's should be the best strategy in this case. But at the end, I had already resected that segment. Then there was a leakage between the P1 and P2 in this case, and I got to repair this small leak. Mitral valve regurg in this case, putting this stitch here. Then, and this is the final aspect of the valve here. Doing the we cannot see very well the valve here, but as you can see, the test showed the valve was competent, because there was no saline leaking to the left atrial. Once more. Then in the OR, we still, once more. And at the end, we did this echo. And as you can see, there is no regurg in this video. As you can see, that area in the anterior leaflet where there was that hole, there is no hole now because of the bovine pericardial patch in here. And the Doppler show no leakage here, as you can see, with a good coaptation area. We were a little bit concerned in this case because the mitral valve orifice could be a little bit, stenotic, restricted, but the echo didn't show that. And this is the final aspect of the mitral valve, showing that also in very complex cases of mitral valve endocarditis, we can be conservative and try to preserve valves very, very, very infected, as we have shown in a case like this. Mainly in patients, in very young patients, we think we should try to be conservative and preserve all the mitral valves. I think these are the last slides. let's do videos. I'd like to thank you once more, and then we could speculate a little bit more if we could do another technique in cases like this, as you have pointed out.
Very nice case.
Dr. Moraes.
What?
Yes.
Starting?
Hello, everybody. I have a question for you. Really nice case. I like Dr. Navia. I prefer to respect the P2 and do maybe a neocord because I want to respect that segment. But my question is, how do you take the measure of the patch of the pericardial patch for the anterior valve?
Yes, that's a good point. In reality, once I had resected the fragile tissue in the anterior leaflet, I could measure the hole and then suture a piece of pericardial patch. I mean, there is no specific way to measure the patch we are going to suture in the anterior leaflets. Of course, you have to be aware not to restricting the hole. It's better to implant, to insert, to suture a bigger than a smaller patch, as that's what I did in these cases, and that's what I usually do in the repairing the anterior leaflets of mitral valves when there is an endocarditis.
Thank you.
Professor
Mateo?
Moraes, may I ask you something? Yeah, thank you. I mean, congratulations for the results. It's a really good result. And I mean, this is probably way better than a replacement, even more if it is a young patient. I know you work in a high volume center in Brazil. I don't know if you used to perform minimal invasive surgery, but how is your experience performing repair in minimal invasive surgery in endocarditis? Because, for example, this will be a good case because it's, let's say, not very complex reconstructions in terms of there is not abscess, there is no calcification, it's just a patch and eventually a cord or a triangular resection. So do you have any experience or recommendation performing minimal invasive surgery for endocarditis in this kind of more or less not that complex repairs?
Mm-hmm. Yes, Mateo, thank you for the question. I have done some minimal invasive mitral valve repair, but not in cases like this. I would be very afraid I don't have such a big experience in minimal invasive mitral valves to be very comfortable to do a repair in a case like this, you see. And then I prefer not in cases like this to where we will not be sure what we'll see when we open the left atrium. We usually do the minimal invasive when we almost know by echo what's exactly what we are going to do. I do not do a robotic mitral valve here in my place, only minimal invasive by minimal right thoracotomy. Yeah.
Fernando, Enrique started this session talking about kind of two schools of thinking. One is some people think in endocarditis you should take everything that is infected out to make sure that you're not going to get another infection. And some people, like in this case, and you had a great repair here, do some repairs like this and keep some of the mitral tissue in without taking it out. So I'm pretty sure in P2 you didn't leave any infected tissue, but in the patch in the anterior leaflet, as Enrique too said, it looks like an active infection. What are you some kind concerned, or are you 100% sure that that's not going to get reinfected? And I mean not in years, but now in the next few weeks.
Yeah, when we treat an infective endocarditis, we will never 100% sure that will not will not have another infection in that area. Of course, we will keep on antibiotics for at least 4 weeks, and then we have to speculate that we have resected that infected tissue, and we have to pray sometimes to not have the case, the valve reinfected. But we were very happy with this, the technique applied in this case, and fortunately the patient did very well. But it's sometimes it's a gamble. You see,
Yeah,
if we do not resect such a tissue in the left, in the posterior leaflet, and just resect a little bit and insert a new corda, perhaps we could have more chance to have residual infected tissue. But once we keep on antibiotics, the chance of treating the patient is very high, in my opinion.
Okay.
And for the cardiologists invited to this meeting, Daniel, Andrea, in your opinion, how many times we need to maintain the antibiotic treatment in cases like that? Do you consider, for example, the microbiology of the resected tissue to take the decision?
Hi. Yes, I think that if I can, I want to make some talking about something about the patient, because I think that it's very important to see the infectious evolution of the patients. Usually use 6 weeks of antibiotics. And if I can, I want to ask if the two things. One of them is when you talk about the opportunity of the surgery in this patient that they have the ACV, and do you use in evaluation with imagine with another embolims that they're not a clinical manifestation about that? For example, duck body, we talk about that in Uruguay, and one of the questions Mateo has just did it, if there are good results with this kind of plasty in these patients between endocarditis.
The question was related to the previous stroke?
Yes, because
Sorry.
this was with previous stroke, but clinically we don't know if he has another embolims. For example, you know, if he have
you mean pre-op? You mean pre-op or post-op?
Pre-op.
Yeah, we never know, but our decision is related to, of course, the physical examination, but mainly related to what we have observed during the cerebral images by the cerebral tomography. Once there were no signs of bleeding and was a very, very small stroke, and patient was clinically well. In here, in our practice nowadays, we decided to go ahead and to not operate at least 1 month in cases like this, where there was a huge mitral regurgitation, you see.
Okay. And you use, for example, if you have kidney embolisms or you have body tomography for know about that, because usually we don't have manifestations clinically about that. But it's very important to know if there is another one before the surgery. I'm not going
you're right. But we know that it's very frequent patients have many embolisms to everywhere, but mainly to the kidney. It's very rare, very unusual to detect these manifestations. Very unusual to appear. I mean, and this is not a contraindication to operate and to fix the valves, in my point of view.
No. Yes, of course, it is not. I'm talking about the complete evaluation pre-op, but I don't know. We have cases that we have ACV, and then pre-op you used to have body tomography, and we have kidney embolisms sometimes. It's another reinforce the indication, for example, not to.
But we would not avoid, I mean, would not postpone the operation if patient has presented this scenario, in this scenario, as you have pointed out. Okay. I think it's another indication to go ahead and to fix the valve.
And about the answer, yes, we used to 6 weeks with antibiotics. That Dr. Enrique has asked about that.
Thank you, Dr. Simeone. Dr. Navia, please.
I got a question for the surgical technique, Fernando. You always use a complete ring? Because sometimes with endocarditis, the mitral insufficiency is not long enough, and it's not chronic, and sometimes the annulus is not so big.
Yes.
That's why in the past we use a complete ring. Now we use posterior bands only. That's why if the annulus is not big enough because the mitral insufficiency is not chronic, sometimes the restrictions potentially it's not a problem.
That's a good point, Dr. Navia. In reality, if the mitral annulus is normal for the patient, I usually do not insert a ring. I prefer to use less tissue in the mitral apparatus than it's possible. I had another case, if I had time to present, where there was a mitral, another hole in the anterior leaflet, where I just fixed the anterior leaflet with a bovine pericardial patch, and do not put a ring once the mitral valve apparatus was normal. What I have our policy here in our place now, once patient has mitral valve endocarditis with the valve damaged, with a structural defect in the mitral valve, we usually here in our place wait just 1 week on antibiotics and try to fix the valve. In our center, we try to fix this kind of patients with a structural valve deterioration, mitral regurg, 1 week to 10 days on antibiotics, and then fix the valve. Unless the patient has other complications.
Yes, in our center, we do like that too. We start antibiotics, we wait for 7 days, and then we go forward to the surgical repair or replacement, depending of the pathology of the valve.
Yeah.
I agree that there are some valves that are easy to repair, and with our experience, we try to do that. But sometimes the compromise is too big, and we cannot repair, and we decide to go faster to replace the valve.
Yes, can I ask you if your team prefer to have the hemocultures negative, or you start antibiotics and 1 week or 10 days go ahead, or you wait to have the blood exams negative?
No, in general, we start antibiotics, and after 7 or 10 days, we go to the surgery.
Okay.
But if the patient have another complication, like an cerebral emboli, then we wait for the neurologist. Then when they give us the authorization, we go to the surgery.
Yeah.
Usually we wait 10 days too, and we want to have a cerebral scanner without hemorrhagic transformation.
Yeah, that's what I do here.
Yes, I want to ask to the audience, if in your experience, do you think that we can repair all valves, or there's someone who goes directly to replace endocarditis, mitral endocarditis? It's an open question. Feel confidence, please.
I think this is a very important point. I think the aortic mitral junction in the echocardiogram is not involved. There is a high chance that you can preserve the valve.
Mm-hmm.
If the abscess is going to the mitral aortic junction, is a risky situation, and you have to start doing just a commando operation or a more big scenario. But I think it's depend on the lesions. A big hole that Fernando treated, I think, is an easy one, and you can fix it. And if you can preserve the mitral valve, it always is better than the prosthesis in this scenario. The antibiotic is going to act very better than have a prosthesis there, and the reinfection is going to be lower if you instead of putting a prosthesis. But it depends on the scenario. I think the most important issue is if the TE show that the mitral aortic junction is involved or not. Because if it's involved, the strategy is different, and the chances to preserve is also different.
Yes, I agree.
Can I have a saying there?
Yeah.
Okay.
Professor Rui, it's a pleasure. It's a pleasure to
it's
have
Professor because I'm a friend of Fernando, so that's why that's the reason. Congratulations for the case, presentation of the case. Congratulations for the discussion. I just want to answer what Dr. Seguel just said. I think there's 2 points to consider when you discuss what you're going to do with the patient. The first one is that nowadays, if you do a mitroplasty without intraoperative echo, you're doing basically, I think that's one of the questions to do to conserve the valve, to do plasty. So the team has got to be an expert on doing conservative surgery, sorry, of the mitral valve. That's the first thing. And I know Fernando is a guy who's been pushing Brazilian surgeons to do plasty of the mitral valve. So I agree with him. The second thing is you have to have at least an echocardiographist on site to do it, because if you don't have it, you probably be with problems around it. Basically, if you don't have an echocardiography, transesophageal echography intraoperative, you have to replace that valve. It depends also on the age of the patient, because I wouldn't dare to do a plasty of the mitral valve in a 70-year patient with or without endocarditis. I'll change the valve at least, unless it's an easy way of doing it. But if it's complicated, I'll put. I'm not paid by anyone, but there's a whole lot of biological valves that are good and will last for 20 years at least. So that's my personal opinion. Thank you.
No, thanks to you.
I think another important aspect is this socioeconomic context of the patient, especially in Latin America. We have a lot of patients from rural towns, and I mean, if it's technically possible, I will think it's better to repair better than replace, because you might never see that patient again. And for example, if you put a mechanical valve, then maybe that patient is not even going to take the anticoagulation. Or if you put a biological one, I mean, it can degenerate and it can be the last time you see that patient again, or even if it recurs. So, I mean, if it is technically possible, it will be maybe convenient to repair according to the socioeconomic status of the patient and the origin.
Yes, yes. I think, I mean, both of you are correct in my point of view. Once someone in the past has used to say the life is a local matter. So I have to apply what's the best we have in our place based on our experience, what we have
It
seen
was
for
Charlie Chaplin,
years.
the guy who said that.
Yes, Charlie Chaplin, that's it. Yeah, but I think it's very applicable in everywhere. Life is a local matter, and then you have to apply the best technique you believe in your place based on your structure in your place. Yeah. Any other comment?
No, just for finishing, we should not forget that in this case, we are treating an infective endocarditis. So this must be the first goal of our operation, to treat the infection. And then we see what can we do with the valve. Sometimes we can repair, but sometimes not. Mm-hmm.
Yeah, it's important.
Well, so Mateo,
apart from that, I think some plasty of the mitral valve is not for every surgeon, but it's for some surgeons that know how to do it. It's better in some cases to, as you said, to replace the valve and have a patient with no mitral insufficiency and have a patient with a minor or even a moderate mitral insufficiency, because he'll come back for sure.
Mm-hmm. Well,
okay, thank you very much. I think that's it. Yeah, and we were exactly on time, 1 hour. So very interesting, the discussion. I personally learned a lot. It was a pleasure, and thank you for joining us. And yeah, I hope to see you next month again.
Okay, thank
you
you all. Thank you for the opportunity.
Thanks for the invitation. Bye-bye to everybody.
Thank you.
Bye-bye.